Everyone, thank you so much for joining this session. I really look forward to this opportunity and really appreciate it. I've cut time a little bit and I was already kind of crunching, so I'm going to go as fast as I can so that we have time for questions. But I wanted to talk about, for my patients that I treat, I'm an oncologist and I specialize in chronic lymphocytic leukemia and other what we could term indolent lymphomas, although us in the field don't love that term, but basically treatable but incurable cancers. And the term survivorship is challenging for those types of patients because they're going to live with this cancer for the rest of their life. Yet they also should hopefully have years as well. And so we need to be optimizing their medical care just like we do survivors, whether they're on treatment or off treatment. And so what we're trying to do is create this chronic cancer care model so that they can feel included and understand how important all of these survivorship services are for them as well. I just really briefly, because chronic lymphocytic leukemia, or CLL as I'm going to refer to it, is the most common leukemia in the US. It's absolutely treatable, but it's not curable. And often you actually don't need to treat right away. And I'm going to go through some patient scenarios to illustrate how this applies to many types of cancers and how the chronic cancer care model applies. But I just want to, I have listed here that it really applies to a lot of different types of cancers. There are other lymphomas, other leukemias, and then really a lot of metastatic cancers these days where people can live for years on various treatments and really need to be focusing on all aspects of their care. And this model really applies to all these situations and how can we help these patients. So these are my patients over here. I have 3 different scenarios I'm going to quickly walk through. This first patient is someone who comes to me who needs treatment right away or pretty quickly. And what happens is these are kind of treatment periods. So they may have a period where they're on treatment, and then they're going to have periods where they might be off or they're on kind of stable therapy. So similarly to metastatic breast cancer, where they may be on treatment but very stable for quite some time. And these are opportunities where we could maximize their health, right? We could do many other things and try to help them continue to do well. Also, this is where they might be experiencing toxicities, mental health stress, many of the things we talk about in survivorship, and how can we help them through these times. The second patient is a patient that doesn't need treatment right away. So again, an opportunity, how can we delay treatment? How can we help them as they're dealing with waiting and figuring out what's going to happen? And then eventually may need treatment. But then unfortunately, and how can we help them maybe delay those complications so they can stay on treatment longer and do better? And then lastly is a patient that maybe doesn't need treatment. In some of these chronic lymphocytic leukemia patients, they don't need treatment, but then a secondary event happens, like a heart attack or a secondary cancer. And how can we help prevent that? And so that is what I'm going to address in the next few minutes as quickly as I can. So cancer and physical activity. We know a lot, but we also don't know a lot. So we know that it improves quality of life and symptoms, fatigue, how people are doing in their day-to-day life. And even in some cancers, we know it actually improves survival. Yet we don't really know how to apply that in a lot of these chronic cancer care situations. There's not a lot of research. And on the other hand, we know how critical the immune system is in all highlighted right now with COVID. And when we look at people who are healthy individuals without cancer, we know that exercise significantly improves their immune system. So there's multiple reasons why exercise could be really helpful for all of these patients. And so what we are trying to do is understand how we can best apply this to our patients. And so the first thing that I did was I looked at just what's our physical activity of CLL patients in clinic. And for those of you who you don't really get a robust evaluation of your physical function when you get there. And so what we did is we gave surveys, we walked people for 6 minutes, we tested strength, and we tested balance. You can see some of the testing we did here. That was not one of our patients, the 6-pack. And we actually found that in just a normal clinic visit that we had almost completely validity of the survey just means it was fully completed, and almost, over 90% were completely valid, and we had full completion. And when we looked at the surveys, they were associated with each other, so people had time to do them and they made sense. And then what we did is we looked at, goodness, our patients active as their age-matched peers. And almost, nearly 60 to 70% of our patients really did minimal activity at all. And then when this is we do to test basically aerobic strength, and we can do that based on the 6-minute walk test and some of the actual strength testing we did in the clinic. And we found again that people were only about 65% of what their peers were. And what was also interesting were that the surveys and the physical function test did not exactly correlate. And why that's important is it's not the patient's life, it's that we all perceive our own activity, all of us do it, as likely more than it is. And so it's really important to what this showed us is we really need to be implementing those physical function tests in clinic so that we can better assess what patients' needs are, so we can actually help people understand where we can intervene to make people stronger so they can have better outcomes. So what are we doing? So we're trying to start to do research. So I am working with an exercise physiologist, and we just completed a pilot study of actually doing exercise training in the gym 3 times a week for patients. Basically, it was a 12-week intervention. You got randomized to either kind of what we would just tell you to do, here's the standard recommendations versus the exercise program. And then we did all this monitoring. You can see down here, this is actually a CPET test. Our basketball players, our football players go through this at the beginning of the seasons. They actually work so hard because they compete against each other that they have to put them in a harness because they'll pass out because they try to compete against each other. We don't do that to our patients. That's not allowed. But what we're trying to do is, so one of the hardest things that we recognize is patients want to be more physical active. They want to eat well. And we have resources here, and the survivorship's amazing. But what we want to do as a clinician is I want to be able to give you not just a prescription of a drug, but how can I actually tell you this is the physical activity you need to do to help your cancer? And that would be so exciting if we could prescribe it. And so right now we've applied for some grants. We're continuing to work on these research points, but that's one element of how can we help people, whether they have active cancer, can we help them be more physically active and improve their cancer, improve their symptoms, stay on treatment, have less toxicities, less fatigue, less nausea, all of those things that we can improve with exercise if we get them the right prescription. So that can certainly help. But what if they're tolerating the drug and it's not just the symptoms, but financial toxicity? And that's another part of this chronic cancer care model. And I just want to highlight, this is really, but in our chronic cancer care treatment and metastatic breast, CLL, a lot of these patients are on treatment for years. And so financial toxicity could be huge because it's not a finite period of time for some of these drugs. And as you can see, studies have shown that 40% of people report a significant burden. People with cancer are 2.7 times more likely to declare bankruptcy. And in another type of leukemia that's chronic, 42% of people are non-adherent to their medications because of the cost. And so what we looked at was, if you look at insurance, and you look at the different plans on the Affordable Care Act, because we have so many new IV drug or new oral drugs, not just IV drugs, and those get billed differently, what happens to patients? And what we found is that everyone reaches their max out of pocket, which if you saw here is up to $8,000 depending on the plan, almost within 100 days. Now, some of these higher plans, which have higher, are kind of the platinum plan, it does take longer, but it still happens. Interestingly, we looked at prostate cancer, and the oral drugs, which are in orange here, similarly reached rapidly. The IV drug, called docetaxel, took much longer, and the reason for that is it's a generic drug. And there's very few generic drugs in cancer because thankfully we're making huge strides quickly, but then they're expensive drugs and they're not generic. So it's rare to have generic drugs. The other thing we looked at is where is the cost? The imaging, the labs, the physician visits, the prescriptions, all of that. A huge part of it is the prescriptions. And I just want to highlight that because part of taking care of patients is recognizing all of the stresses that are happening. And what we help patients better manage these costs, meeting with our financial counselors, helping them pick the appropriate insurance plan, because that can sometimes be very elusive and could really change how quickly you meet the costs. How we as a center can help reduce costs of drugs and treatment through donations, through patient advocacy groups, and through assistance. We have drug assistance. So a lot of things that we're trying to do to help patients so they can stay on their drugs and continue to do well. So what if it's toxicity actually, and not financial, like a toxicity of the drug, so a symptom and not just the financial piece. So ibrutinib is one of the major earth-changing drugs for our CLL patients and really a lot of patients. It has changed the outcomes of some of our most aggressive patients to living for a few years to living for a decade. It's really been huge. The problem is it also does come with its own side effect burden. And when we look at real world data, 42% of people eventually at 2 years discontinue because of side effects. There are joint aches, AFib, and things that aren't your typical chemo. Big one is hypertension. 75% with controlled hypertension prior to starting the drug then become uncontrolled and need additional medications. And nearly 50% will develop new hypertension who didn't have it before. The whole reason I'm highlighting this is one, this is again where exercise and nutrition come in, but also where some of the programs that we're trying to implement. So Dr. Eppinger is going to be highlighting this in another, but the one team study is basically, it's highlighting how we're working with patients to control their comorbidities, all of their other issues that they're having, so that people can tolerate the drugs better and we can keep them healthier. So that while we're treating their CLL, they don't have a heart attack or some other major life-changing event. And so the one team study is how do we make sure that oncologists and primary care doctors are working together so that we can control these side effects, keep people on medication, and keep people doing well. And so it's really highlighting this needs to be a part. Lastly, I'm really as fast as I can, so secondary malignancies are a big problem. And if you think about it, it's for a couple of reasons. One, these people can live for a long time with these cancers, but also there's an immune dysregulation that's part of these cancers, and that allows for other things to happen, like secondary malignancies. So this is a busy slide, but I just wanted to point out that people with chronic lymphocytic leukemia are 2 times more likely than the average person to have a second cancer. And so that is skin, GI, all sorts of things. And why does that matter? Of course, it decreases survival and also is a huge impact on people's quality of life. In fact, there's certain types of CLL patients where the secondary cancer is actually their biggest risk of life. And I just wanted to highlight the Duke data that I've analyzed, and we have almost half of our patients have a secondary. This is the problem. Screening. It's the standard screening we do for the population. And so what we want to do is study this and figure out how can we make new recommendations that change this and make sure that maybe we need to change our screening policies. And so this is the big long-term picture. How can we help people with their secondary cancer? And what should be on this chronic care model is also mental health and as well. That's part of all of this. But this is the patient and their family. And while treatment is absolutely vital, it's all the aspects of their care. And that's kind of how we view it, and we want to try to help become the standard. So